definitions. Please excuse me if I use these terms a little loosely. Haha. Diarrhea is the passage of abnormally liquid or unformed stools at an increased frequency. For Western diet, this is more than 200 grams per day. Chronic diarrhea is pretty rare in the Western world. It does require further evaluation. In kids and old people, we may see overflow diarrhea if there's a fecal impaction, where stools leak around the impacted area. Pseudodiarrhea is a frequent passage of small volumes of stool, often with rectal urgency, tenesmus, which is the urge to defecate despite an empty colon, or feeling of incomplete evacuation. Fecal incontinence is an involuntary discharge of rectal contents, which may or may not be associated with diarrhea. Non-infectious diarrhea has 4 basic pathophysiologies: osmotic, secretory, inflammatory, and alterations in motility. We use the Bristol stool chart, to estimate GI transit time. It may indicate motility issues. So type 1 is very separate hard lumps like nuts, hard to pass, kind of a constipated type of stool, while type 7 is watery, no liquid pieces, it's entirely liquid, indicative of hypermotility and or inflammation. Don't take the time to memorize this chart, but pay attention to the items in red. The chart's looking at categories of diarrhea as characterized by the type of stool. So inflammatory diarrhea will probably see frequent small volume, sometimes bloody stools, often with tenesmus. We're not going to talk too much about that today. In fatty diarrhea, hopefully by now you'll recognize that lack of pancreatic lipase or blocking of pancreatic lipase by orlistat can lead to steatorrhea, and steatorrhea puts patients at risk for oxalate kidney stones. For watery diarrhea, there's 2 potential pathophysiologic causes. One is osmotic, the other is secretory. In osmotic diarrhea, we have intake of unabsorbed ions or sugars. Think about those sugar alcohols that we talked about that are only 50% absorbed. The remaining 50% gets into the colon where it draws in water through osmosis, leading to watery diarrhea. Magnesium can also cause diarrhea through an osmotic effect. With secretory diarrhea, we often see irritation. Things like bile acid malabsorption can irritate the gut, causing lots of secretion and a watery diarrhea. So with bile acid malabsorption, we'll see that we can use cholestyramine, which is a bile acid sequestrant. Also notice that sometimes endocrine tumors may cause a secretory diarrhea, VIP-omas, for example, vasoactive intestinal peptide omas. In that case, we might use octreotide. One class of drugs that has significant impact on the GI tract is the opiates. Opiates and opioids decrease motility and water secretion. Again, both motility and secretion are impacted by opiates. Mu and delta opioid receptors close voltage-gated calcium channels presynaptically, reduce cyclic AMP formation, and open postsynaptic potassium channels. Opioids inhibit release of acetylcholine and substance P while increasing release of vasoactive intestinal peptide and nitric oxide, which leads to dysfunctional GI contractility and tone. When we use opiates and opioids for pain, constipation is really one of the most aggravating side effects. However, we can use opiates and opioids to treat diarrhea since opioids decrease both motility and secretion. Drugs in this class that we use for diarrhea include diphenhydroxylate with atropine, Lomotil. Atropine's added both for the antimuscarinic effects and to help reduce risk of abuse. Loperamide, Imodium, which doesn't cross the blood-brain barrier because it's a substrate of P-glycoprotein efflux. We also have the product Paregoric, which is camphorated opium tincture. Mechanism of opiates and opioids in the GI tract for diarrhea: inhibition of activation motility because of inhibition of serotonin release, and increased water resorption. Adverse drug effects: severe constipation, and sedation for drugs that cross the blood-brain barrier. There's also a risk of abuse and dependency. FYI, elaxadiline Viberzi is a Schedule IV controlled substance that's a mu and kappa opiate receptor agonist and a delta receptor antagonist that's used to treat irritable bowel syndrome with diarrhea. Practice time: a 20-year-old male develops torsade de pointe. His girlfriend admits that they took an OTC medication combined with green tea and black pepper to get high. Which over-the-counter drug is most likely responsible? Cimetidine Tagamet, dimenhydrinate Dramamine, famotidine Pepsid, loperamide Imodium, or omeprazole Prilosec. The correct answer is loperamide Imodium. High doses of loperamide can lead to increased CNS levels and hence abuse, especially if combined with P-glycoprotein inhibitors like those found in green tea and black pepper. Ventricular arrhythmia from loperamide abuse has caused several deaths. A drug that we've already seen that's often used for diarrhea is Pepto-Bismol, bismuth subsalicylate. Again, the bismuth combined enterotoxins, it's antimicrobial. The problem is it may turn stool and or tongue black. The subsalicylate blocks prostaglandin formation, therefore it blocks secretion. There's a risk of Rye syndrome, which is a type of hepatic encephalopathy in pediatric patients with viral illness, and there's also a risk of salicylate toxicity and overdose. As previously mentioned, bile acid malabsorption may lead to a secretory type of diarrhea. Bile acids are very irritating to the GI tract. Bile acids normally undergo enterohepatic recycling, with active resorption occurring primarily in the distal ileum. Bile acid-related bowel dysfunction may be associated with irritable bowel syndrome with diarrhea, IBS-D, and also an idiopathic bile acid diarrhea. Enterohepatic recirculation of bile acids is important in bile acid malabsorption. Ileal enterocytes absorb bile acid through a receptor-mediated process. In the lower portion of the diagram, we see the ileal bile acid transporter, IBAT, while the upper portion of the diagram revisits hepatic bile acid disposition. Once again, intracellular bile acids activate the farnesoid X receptor to increase fibroblast growth factor 19 synthesis. FGF19 in the portal circulation downregulates hepatocyte bile acid synthesis and absorption and increases hepatocyte bile acid efflux. Cholestyramine, questran, and cholesevolem Welchol are bile acid binding resins. They're positively charged resins that can bind to bile acids, leading to their fecal elimination. Low bile acid concentration increases the expression of CYP7A1, which increases bile acid synthesis from cholesterol, so cholesterol actually gets lowered. It's another use for these drugs. But simultaneously, as we lower the cholesterol, we're going to see an increase in triglyceride synthesis. So one of the biggest adverse effects is going to be hypertriglyceridemia. We may also see fat-soluble vitamin deficiency, since vitamins A, D, E, and K are going to bind to the bile acid resin also. They're also associated with significant GI distress and constipation when they're used for dyslipidemia. In the lower diagram, we're looking at the intestinal lumen. It's depicting the cystic fibrosis transmembrane regulator, which is activated by cyclic AMP to secrete chloride, causing watery diarrhea. In the case of cholera toxin especially, that can activate adenylyl cyclase. We also see that the rotavirus can activate the calcium-activated chloride channel, CACC, to cause secretion of chloride, leading to watery diarrhea. The drug crofelemer, Mytesi, which is a tannin isolated from the tree Croton lecleri, is a CFTR and CACC blocker. It's used for non-infectious secretory diarrhea caused by some of our anti-HIV drugs, the protease inhibitors, reverse transcriptase inhibitors. It's also used off-label for those with short bowel syndrome. FYI, some geranium species, shown here as the cranesbill, the roots contain gallotannin, gallotannic acid, and or gallic acid. These tannins can also block the CFTR and pretty effective for diarrhea, even cholera-level diarrhea. If it's important enough to test on, it's worth repeating again. The pancreatic lipase inhibitor orlistat causes weight loss by inducing steatorrhea. Steatorrhea may lead to fat-soluble vitamin deficiency, loss of A, D, E, and K, and it may also lead to formation of oxalate kidney stones. In the urine, oxalate forms both bow-tie-shaped and rhomboidal crystals. This diagram illustrates somatostatin's ability to turn off secretion of just about everything. Octreotide, brand name sandostatin, is a somatostatin analog. It inhibits the secretion of many hormones, including vasoactive intestinal peptide. Vipomas are VIP-secreting tumors causing severe diarrhea, while carcinoid syndrome is caused by tumors that secrete excess serotonin, which also causes severe diarrhea. Octreotide, sandostatin, is used to treat vipoma and diarrhea from carcinoid syndrome.